Hey everybody, welcome to another episode of Dropping Knowledge. Guys, sticking with my chronic diseases and disabilities series, today I want to talk to you about obesity. The selected chronic disease precipitated by physical inactivity and resulting healthcare costs in the United States. List obesity at $117 billion. Alright. Annual cost, guys. So this is a major situation here, right? We're going to cover it extensively, so please stay right there. Go make yourself something to eat. Maybe you could listen to this while you're doing your cardio. Alright guys, I got a lot of information to cover. Obesity is defined as an excessive accumulation of body fat. This is associated with numerous comorbidities, and many of these are life-threatening. Prevalence estimates of the number of obese children and adults vary depending on variations in obesity classification systems and ethnic origins within population samples, as well as other factors. In 2006, population-based estimates revealed that 33 1/3 of U.S. adult men and 35.3% of women aged 20 years and older were obese. That means their body mass index was greater than 30. This includes notably higher rates of obesity in Hispanics and non-Hispanic black women in particular. A BMI level above the 95th percentile for age and sex, or exceeding 30, whichever is smaller, is the standard by which obesity is classified in children and adolescents. In 2006, population-based estimates indicated that 11.3% of U.S. children and adolescents had a BMI at or above the 97th percentile for age and sex, while 16.3% were at or above the 95th percentile. This is an unfortunate trend that has lasted more than 2 decades and steadily increasing. The rate of obesity, it appears that since the end of 2006, obesity rates for U.S. children and adults have stabilized, at least for some time being. Obesity is a complex, multifaceted disease involving, among other factors, hypothalamic, endocrine, and genetic disorders, the environment and behavior. A common misconception is that the primary cause of obesity is overeating. In fact, most evidence suggests that energy imbalances resulting from the consumption of excessive total calories, this is especially a diet high in fat and refined sugar, or from a sedentary lifestyle, or from a combination of the two, is the primary cause of obesity in the United States. In the United States, as well as many other industrialized countries, the rapid appearance of obesity is largely fueled by the exploitation of accessible, abundant, and inexpensive energy-dense foods, and the substantial reduction in average daily energy expenditure required for survival. The human body has difficulty adapting to chronic periods of energy imbalance, as indicated by the altered physiology response associated with obesity, which is included in the following: increased fasting insulin, increased insulin response to glucose, decreased insulin sensitivity, decreased growth hormone response to insulin stimulation, increased adrenocortical hormones, increased cholesterol synthesis and excretion, decreased hormone-sensitive lipase. The primary mechanism, etiology, and maintenance of obesity is altering insulin function. The primary difference between identification, definition, and classification of obesity and the overweight is the assessment of body fat. In addition to percentage of body fat, factors to consider in determining the degree in which obesity impairs health are the location of fat deposits and other comorbidities. Ideally, obesity should be classified based on body composition assessments, but this rarely occurs, especially in large population samples. Since the National Institute of Health recommended using BMI to define and classify obesity in 1988, BMI has become the accepted international standard for classifying obesity and overweight for large population-based studies. It is interesting to note that the BMI is a crude measurement that doesn't quantify body composition. From a public health standpoint, it correlates fairly well with the subcutaneous body fat in majority of individuals and is easy and very convenient to obtain. Obesity has been defined with the use of many systems, most commonly height weight tables, BMI, and body fat percentage. More recently, in addition to these calculations of BMI, body fat distribution has been estimated using waist circumference. Current population-based BMI and WC classification levels are shown in this handy little table I'm going to show you. The body fat percentage for men and women 18 years and older can additionally be used to identify obesity and stratify obesity-related health risks. Also be classified based on phenotype, fat cell morphology, and overall health status. Although these methods constitute more theoretical versus practical applications. Now I'm going to go over these little classifications. We're going to go over the phenotype. Phenotype, type 1, excessive body mass or percentage fat. Type 2, excessive subcutaneous truncal abdominal fat, android. Type 3, excessive abdominal visceral fat. Type 4, excessive gluteal femoral fat, cell morphology. Hyperplastic obesity. Hypertrophic obesity. For the classification of health status, there are two. One could be mild obesity, and the other would be morbid obesity. Obesity increases the overall risk and severity of numerous diseases. Listen up, guys. This is important. I want you to stay healthy. The distribution of body fat may contribute more to disease than total body fat alone. Upper body fat distribution, which is known as android obesity, is strongly correlated with increased risk of coronary artery disease, also known as CAD, hypertension, hyperlipidemia, and diabetes, as well as hormone and menstrual dysfunction. Truncal adipocytes are unique in that they are metabolically more active and secrete proteins, adipocytokines, that control various metabolic functions. The higher the metabolic activity of these adipocytes is associated with insulin resistance, hypertension via increased sodium retention, sympathetic nervous system activation, increased intercellular calcium, and hypertrophy of smooth muscle vessels. Abdominal adipocytes are also associated with increased very low dense lipoproteins, triglycerides, and adipose lipoprotein lipase activity. So it is clear that excessive fat accumulation in specific body areas likely contributes more to increased disease risk than the classification of obesity alone. Guys, look, like I have always said, if you're, overweight, you're basically carrying around a sack of poison. And depending on how overweight you are, right, how much your BMI is, that's how large your sack of poison is. That's how much more damage it could do. 10 pounds, 20 pounds, 30 pound, 40. It just starts going up incrementally. Another body fat distribution assessment technique, waist to hip ratio, also correlates with disease risk prediction, especially CAD risk. Although risk varies with age and sex, the recommended technique for assessing weight to hip ratio is to measure the minimal waist, this is at or above the umbilicus, and divide by the circumference of the hips at the widest gluteal level. Standards for the waist to hip ratio are as follows. Lower body fat distribution for men is going to be less than 0.776. Lower body fat distribution for women, less than 0.776. Upper body fat distribution for men, greater than 0.913. Upper body fat distribution for women, greater than 0.861. I guess that's like a little snapshot of what it is. Now let's go into the effects on exercise response. All right, so I just want you to open your minds a little bit. Think about it. If someone's obese, right, their daily living activities are that much more challenging. Why? Because you have this massive amount of load that you're carrying around on your skeletal system, your muscular system, your organs, right, your body. So it suffers, right? Your joints are definitely at great risk. So it's just like carrying around a giant amount of weight with you all day, like a burden, and you just got to carry this thing. I don't want anybody to carry these burdens. So lay them down. So here we go. Let's go into it. Let's go to the effects on exercise response. So besides the overall low functional status of this population, one of the most discernible effects of obesity on the exercise response involves the way in which obesity adds stress to the joints. It affects movement. It affects gait. It increases foot pressure. It decreases strength. And subsequently, it increases the risks of osteoarthritis. Apart from the biomechanical effects, other common comorbidities of obesity include diabetes, hypertension, CAD, and sleep apnea. Increase the overall risk of exercise and can affect the exercise response. Social and behavioral factors associated with obesity, such as past experiences with and current fears of exercise, should also be considered. Prior to any formal exercise, including exercise testing, a comprehensive health history and, if possible, medical history should be obtained from all obese clients. Exercise training, alone or in combination with calorie restriction, is an effective intervention for reducing body weight and favorably altering body composition, especially in mildly to moderately obese individuals. In morbidly obese individuals, however, exercise and calorie restriction as a primary intervention is typically ineffective. Although it later becomes important in weight maintenance, the benefits of regular physical activity and exercise in the treatment of obesity are numerous. These include prevention of lean body fat mass despite caloric restriction, improved insulin sensitivity, favorable changes in metabolic rate and lipid profiles, reduced blood pressure, improved mood, possible effects on satiety and overall reduction in comorbidity risk. Physical activity also promotes loss of regional fat, especially abdominal fat deposits. A number of research studies have confirmed that exercise alone or in combination with caloric restriction is more effective in reducing abdominal fat cell size than diet alone. Thus, the most efficient means of reducing abdominal fat is through exercise. Physical activity may be one of the most important factors in the maintenance of weight loss because of the resultant increase in energy expenditure, or because this positive behavior change indirectly influences caloric intake. Research has clearly shown that energy expenditure following exercise remains elevated above pre-exercise levels. The degree of elevation depends primarily on the type of intensity and exercise, and to a lesser extent, the duration. The elevated energy expenditure following exercise can have a significant impact, in some cases, on the total number of calories expended. Although highly trained endurance athletes can exhibit higher overall resting metabolic rates, there is little evidence that the type and intensity of exercise performed by untrained obese individuals produce any significant lasting increases in the resting metabolic rates. Metabolic rate, including the caloric cost of physical activity, does not appear to decline with weight reduction. In the starvation state, however, the maintenance of metabolic rate through exercise may not always counteract the reduction mediated by food restriction. Exercise training also has profound effects on glucose metabolism in both moderately and morbidly obese persons, and these would include decreased fasting glucose, decreased fasting insulin, increased glucose tolerance, and decreased insulin resistance. These changes can occur with and without changes in body weight or body fat, with the most dramatic changes occurring in those who have exhibited the greatest reduction in visceral fat. Reduction in fat weight with the preservation of lean body mass is the primary objective of obesity management. Those who are most likely to be successful in weight loss include people who are slightly or moderately obese, have upper body fat distribution, have no history of weight cycling, have a sincere desire to lose weight, and became overweight as an adult. The most common and widely accepted interventions for the treatment of obesity is behavioral change focused on dietary and activity habits towards weight reduction. More invasive interventions may be more appropriate in morbid or extreme obesity. That's when the body mass is greater than 40%. The most common Food and Drug Administration approved drugs for the treatment of obesity are based on reducing fat absorption, suppressing appetite, and stimulating the central nervous system. The FDA has approved 2 invasive methods for treating obesity that are based on reducing the size of the stomach and lowering the absorption of nutrients in the intestine. Individuals with a body mass of greater than 40 or between 35 and 40 with comorbidities such as diabetes, mellitus, and hypertension are eligible for bariatric surgery. The surgery of obesity has been shown to address most of the obesity-related comorbidities, body weight, by an average of 50% to 60%. Laparoscopic gastric banding, which is known as the lap band, is a minimal invasive surgery that involves the placement of an adjustable silicone band around the top portion of the stomach, creating a small gastric pouch that reduces the capacity of the stomach and produces a feeling of fullness shortly after eating. The lap band has numerous benefits, including less surgical trauma and pain, faster recovery rate, and rare operative mortality. The RYGBP, which is known as the Rooks and Y gastric bypass, is a more invasive surgical procedure that reduces the capacity of the stomach. A smaller pouch is created at the top of the stomach that is then connected directly to the middle portion of the small intestine, bypassing the rest of the stomach and the upper portion of the smaller intestine. The RYGBP procedure has a higher mortality and complication risk than gastric banding because the surgery is more invasive. So let's go over some recommendations for exercise testing. Standardized exercise protocols may be appropriate for people who are obese once they have been cleared for testing. However, low-level protocols are recommended because of the low functional capacity of most individuals in this group. The exercise testing protocol should also take into consideration any comorbidities, orthopedic limitations, or current medications. Arm or leg ergometry may be more appropriate for some patients, depending on orthopedic limitations and weight limits of treadmills. Test sensitivity for CAD may be low in this population due to associated comorbidities, orthopedic limitations, current medications, and poor motivation. Exercise testing may not always be necessary for obese adults who want to start an exercise program. In many cases, the initial exercise intensity is far below the point at which cardiac risk is concerned during exercise. Nevertheless, exercise testing plays an important role in the optimal management of exercise treatment for individuals who are obese. The primary objective of exercise testing for this group is ultimately to develop a safe and effective exercise prescription. Disease diagnosis is the secondary, yet essential, objective as well. Determining physical work capacity is important for selecting the intensity of exercise for obese individuals. One can make this determination in a number of ways, including exercise testing using the 12-minute walk or treadmill or cycle ergometer test. For example, important considerations regarding obese individuals during exercise testing include the following: an increased risk of orthopedic injury, an increased risk of cardiovascular disease, an increased risk of heat intolerance. The exercise prescription for obese individuals must optimize energy expenditure, yet minimize potential for injury. Exercise also should be enjoyable and practical and should fit into a person's lifestyle. One should consider the energy expenditure of the actual exercise as well as that of the recovery period. When determining the total energy expenditure for a single exercise session, in some cases, 2 or more short sessions a day is more tolerable and can result in the same or even higher total energy expenditure than one long session of the same intensity. The use of 2 or more short sessions has been recommended because the elevated energy expenditure of recovery may be sustained for a longer period of time than after a single session. However, a single longer session may have an advantage for substrate utilization and for ease of incorporation into some people's lifestyles. More recently, the accumulation of physical activity during the day has been promoted. This may distribute the caloric energy expenditure throughout the day in the absence of formal exercise sessions. The focus of substrate utilization in weight reduction may not be important compared to the total calories expended. The American College of Sports Medicine recommends accumulating 200 to 300 minutes a week or greater than 2,000 kcals per week of physical activity for weight loss and weight maintenance. Progression to the longer duration and total calories should be gradual because the initial exercise intensity and duration levels are low for people who are obese. The exercise recommendations are fairly general. Insert Table 25.6. Just going to go over some of these modes. Non-weight bearing exercise, walking, increase in activities of daily living, resistance training. Frequency, daily or at least 5 sessions per week. Duration, 200 to 300 minutes minimum a week. So you got 30 to 60 minutes a day. Intensity, 40% to 60% of peak oxygen consumption. That's your VO2 peak right there. Exercise intensities of 60 to 75% of your VO2 peak can be prescribed, providing the risk of injury is minimal, accumulating a greater than 2,000 kcal per week. Exercise programs that include high resistance activities, such as free weights, resistant machines, can lead to preferential retention of lean body weight. However, aerobic activity has more potential to decrease fat weight than does resistance training because it can be sustained for longer time, allowing expenditure of more energy. Here's some special considerations. Exercise is not as effective if the obese individual is not motivated or ready to make the necessary changes. Motivational strategies are often required to help clients move into readiness for change. These strategies can include goal setting and decision or balance sheets. Injury prevention is another important consideration in exercise for obese individuals. In fact, physical injury may be one of the primary reasons for discontinuation of exercise. Excessive body weight may exacerbate existing joint conditions. Another concern is thermoregulation. The following considerations and guidelines are relevant for exercise programming in obese populations. Prevention of overuse injury. Injury history. Adequate flexibility, warm-up and cool-down sessions. Gradual progression of intensity and duration. Use of low-impact or non-weight-bearing exercise. Thermoregulation. Neural temperature and humidity. Time of day. Should be cool. Okay, that's important. Adequate hydration. Clothing should be loose-fitting. All right, guys, I'm going to wrap it up here. Other considerations may depend on diseases that coexist with obesity. I got some information for you guys. Here's some websites. Here's the National Institute of Health, the Practical Guide, Identification, Evaluation and Treatment of Overweight and Obesity in Adults. You can find this at www.nih.gov/guidelines/obesity/. National Institute of Health and National Heart, Lung, and Blood Institute clinical guidelines on the identification, evaluation, and treatment of overweight and obesity in adults. Evidence reported. Bethesda, MD, NHLBI. That was 1998. And you can find this information available at www.nih.gov. And then we have the Diagnosis and Treatment of Obesity in Adults, an Applied Evidence-Based Review by J. Am. Board Fam Med. And that was in 2004. And here's a website. Is www.nih.nih.gov. Alright guys, so that finishes this one. As you can see, regardless of what chronic disease you are currently challenged with, that's no excuse. There are proper programs, frequencies, and variables that can optimize and give you a greater outcome in regards to your health and wellness. So with that, I'm going to end this video. I wish you well. If you liked it, you know what to do. Hit that like button, subscribe, comment, share, and I'll be back with another one.